Okay, we're back talking about tension pneumothorax. So high flow oxygen decompress affected side. But like I said just a minute ago, don't be afraid to decompress someone's chest, okay? The worst thing that can happen is you can cause a small pneumothorax, which is never a good thing. You never want to cause harm to a patient. However, with a tension pneumothorax, this is a life-saving maneuver. In traumatic cardiopulmonary arrest in many EMS systems, they recommend doing bilateral chest decompressions during the resuscitation. And in the Good Sam EMS system is our protocol to do so. So like I said, these patients are load and go. You need to get them going. One thing you guys definitely need to know, write this down, take a picture of it, do whatever you got to do. Cardiac tamponade is when blood fills in the sac around the heart, squeezing the heart into submission. When you see this, you're going to see this Beck's triad, not be confused with Cushing's triad or Cushing's reflex, which assigns symptoms of increased intracranial pressure denoted by hypertension, bradycardia, and irregular respirations, either Cheyne-Stokes biots or some other adventitious pattern. But Beck's triad assigns symptoms of something squeezing your heart, i.e. a tension, or not tension, excuse me, a cardiac tamponade. So Beck's triad, we see a low blood pressure, we see neck vein distension, and muffled heart tones. When you listen to the heart, just like we, practice in classes, the heart will sound very distant. So and I know I haven't done this for a while, but if you use your own stethoscope, you'll be able to listen to these lung sounds. They'll sound muffled. But remember, if you have low blood pressure, that means decreased cardiac output. If you see jugular venous distension, it means back pressure on circulation. The only thing that could really cause those two things to happen is, one, cardiogenic shock, late stage. Two, cardiac tamponade leading to cardiogenic shock, also an obstructive type shock. So the heart is being really squeezed really well. So remember that Beck's triad: low blood pressure, neck veins are distended, heart sounds are muffled. Paradoxical pulses are something you see where you have your pulses don't match. Also, you might see your pulses affected on inspiration and exhalation, and your breath sounds will be equal in this case. You can have a cardiac tamponade and a tension pneumothorax. You have more than one injury, but generally you tend to see cardiac tamponade from major myocardial contusions or sternal fractures. So you may have very equal lung sounds, but the hearts will be muffled, low blood pressure, jugular venous distension, Beck's triad. Okay, the treatment for this: high flow oxygen. Get these patients to a hospital that can fix that. Treat for shock. Volume administration. Titrate to peripheral pulse is what they recommend. And a blood pressure of 80 to 100. Granted, 80 is getting a little bit low, but permissive hypotension. And treat dysrhythmias as appropriate. Remember, the patient is in a dysrhythmia from a traumatic event. So the ones you'll treat: ventricular fibrillation, ventricular tachycardia, things like that. If the heart rate is low in the presence of trauma, okay, it's probably not because they're in a heart block. It's probably not because they need atropine. It's probably a compensatory mechanism from increased intracranial pressure. So remember Cushing's triad. When you see a slow heart rate in the presence of trauma, it's either been a prolonged event, meaning it took a while to find this person, or it's a mechanism for prevent increased intracranial pressure. You want to monitor for hemothorax and pneumothorax. Okay. Other things: myocardial contusion, bruise. Okay, this picture should look very familiar to you. It looks very similar to pictures we've shown of myocardial infarctions, where you get decreased oxygenation causing ischemia, which is lack of oxygen to the heart, leading to a myocardial infarction. Myocardial contusion is not caused from a vascular issue, causing issues such as a myocardial infarction caused from either a coronary vasospasm or caused from arterial and atherosclerosis. This is caused from a collection of blood on the heart. And remember, myocardial contusions don't contract very well, don't conduct electricity very well. You may have issues. They'll have chest pain, they may have dysrhythmias, and they may have cardiogenic shock, which is very rare. However, depending on how bad it is, and remember, myocardial contusion, you may have other issues along with it. We want to do 12-lead ECGs or EKGs. We want to treat it as a cardiac tamponade and get a patient. Remember, not all chest pain is chest pain. Okay, it may present the same as a myocardial infarction. They may have ST segment elevation to more contiguous leads. And yes, you might say that they might have been having a heart attack when they crashed their car into a tree. However, without being able to view the inside of the patient, most of our treatments for myocardial infarctions are not that beneficial at all, and actually it could be very risky and cause detriment to your patient. So chest pain, chest trauma, do not give nitrates. Do not dilate vessels on a trauma patient. Okay, don't do that. Okay, do not give them aspirin. Aspirin sticks to the platelet for life of the platelet. You will affect their clotting factors. So what I'm basically saying here is don't get tunnel vision. Also, if you're going to give pain medicine, try to avoid morphine, because morphine 2 to 4 milligrams will cause some vasodilatation. You could treat with a drug more like fentanyl, which tends to have lesser of effect on blood pressure and a little shorter duration. Dysrhythmias, treat all life-threatening dysrhythmias per standard ACLS type guidelines. So ventricular fibrillation needs to be treated with immediate defibrillation. Biphasic energy, if we remember, is 200 joules. Monophasic energy is 360. Ventricular attack without a pulse is always treated the same as ventricular fibrillation. And then we want to try to give, after that, we want to do a very effective CPR. But remember, in a myocardial contusion, we're compressing a heart that's got a myocardial contusion. However, we don't know that. There are technologies that are out and becoming more pre-hospital friendly, which I'm fairly excited about, such as pre-hospital ultrasound, where you'll be able to, in the field, diagnose a pericardial tamponade, or you may even see a disruption of flow from a massive myocardial contusion. So, I'm very excited about pre-hospital ultrasound. Hopefully it goes a long ways and gets cheaper and more accessible out there. So, obviously, do 12-lead EKG, and then also, like I said, treat as cardiac tamponade. Traumatic aortic rupture, most common cause of immediate death. So these folks, you find them and they're, 80% die immediately. So motor vehicle collisions, you see these from, a lot of times you see them from a shearing injury. Or falls from major heights. So the scene size up, always assess the scene for scene safety. Make sure you got body substance isolation on as appropriate. You may see hypertension in upper extremities and hypotension in the lower extremities, which is fairly rare, depending on whether it's high in the aortic arch or it's more in the descending abdominal aorta. So when you palpate the abdomen, if you feel a pulse in the abdomen, obviously do not push on it anymore. A pulse in the abdomen is something you really should not feel. So depending on, like I said, where the rupture is, it could be a leaking issue, or it could be just a full-blown rupture where it's a non-salvageable wound. Tracheobronchial tree injury, subcutaneous emphysema, air under the skin is what we see there. We'll see it mostly in the chest, You'll see it up in the face, and you'll see it in the neck. People for years have always said it feels like Rice Krispies under the skin. I don't necessarily know how someone would know what Rice Krispies under the skin would feel like unless someone's actually had Rice Krispies under their skin, which I find to be highly unlikely and improbable. But with that said, I guess it's a texture thing. So, it feels a lot like, if you want to feel what subcutaneous emphysema feels like, you can get some itty bitty like bubble wrap and then put a pillowcase over it and then palpate that. And that feels more like what subcutaneous emphysema feels like. Okay. Whenever you have air leaking, always monitor for pneumothorax. Remember, a simple pneumothorax can progress into a tension pneumothorax fairly easily, which is resolved fairly easily with a needle thoracentesis. And also monitor for development of a hemothorax, which could generally only be fixed by a chest tube. Diaphragmatic tear. Diaphragmatic tears will affect your breathing. Remember, we breathe in a negative pressure system. The diaphragm has to drop. The intercostals have to pull chest wall out, and sternocleidomastoid have to pull chest wall up. So you may have herniation of abdominal organs, meaning you might hear bowel sounds up into the chest, which is very rare, but you may see it. Abdomen will appear to be really, in proportion, so it won't be symmetrical. Breath sounds will be diminished if they have pressure on the diaphragm or diaphragm is ruptured. And it's by far most common to occur on the left than the right, just because that's a weaker area of the diaphragm than the right. And there's less structures over there, supportive structures. Pulmonary contusion, a very common chest injury. Pulmonary contusions, one of the things we'll complain about is chest pain a lot of times. It may take hours to develop. Any type of bruising to chest. This is one of the trends I've been seeing in EMS is that, we see that seatbelt abrasion across the chest, and you're like, well, you'll be sore for a little bit because you got abrasion from the seatbelt. But a seatbelt abrasion, remember, an object motion will stay in motion until the transition of force. So we want to keep that in mind, that a pulmonary contusion can happen hours to develop, and these patients, if a bad enough pulmonary contusion or severe enough pulmonary contusion, can end up needing ventilation support through a ventilator. So they may have a lot of hypoxemia. They may have a ventilation perfusion mismatch. So they may have adequate oxygen carrying capacity, but decreased ability to make gas exchange because of the pulmonary side of it, from blood filling the alveolar space, causing decreased alveolar volume and decreasing the amount of oxygen that's able to be transferred to the red blood cells. A blast injury. Blast injuries are generally bad. You might see penetrating trauma. Something blows up and shrapnel or other objects around you will penetrate the body. The internal deficits of this type of injury, though, are very hard to assess in the field. And if you don't recognize them, they can be very lethal. So anybody that's been around any type of explosion, and I'm not, when you think of explosions these days, you think of pipe bombs and things like that, but you can very easily have explosions at industrial sites and things like that. Remember, the coal mines use considerable amount of dynamite, and we have lots of coal mines in southern Illinois. So you can have blast injuries, and you have lots of other issues from explosions. So, and with blast injuries, generally we'll have a blast wave, which have transition of force, which can cause solid organs to bleed and hollow organs to rupture. When you have the primary blast injury, something blows up, you can get hit by some shrapnel, and then you could be thrown into something else. So you can have, secondary and tertiary and ongoing type trauma with those. Impaled objects. Here they show some kind of a knife. If it's in the chest, unless something is impaled in the cheek affecting breathing, you never remove a stable object. You want to stabilize it. Monitor for tension of thorax, hemothorax, or cardiac tamponade. If remember, the diaphragm separates the chest cavity from the abdominal cavity. So if you have a knife wound like this, we need to suspect that we're going to have also abdominal issues as well as thoracic issues. If a knife is inside the heart, and you can generally maybe see it moving when the heart beats, be very careful stabilizing those. You want to stabilize it to, slow movement, but you don't want to tighten it down or you cause more damage as a result of that. Traumatic asphyxia. This here is a person who is obviously dead. Severe compression. You get trapped under something heavy from crush injury. And you might get blood vessel rupture all over. You may get, your tongue may swell out of your mouth. Your eyes may kind of bug out. Major hemorrhages. Cyanosis above the crush. So sometimes we see these where the patient might be blue from nipple line up, depending on where they're crushed at. Okay. Other chest injuries, simple pneumothorax could happen either through trauma or through other pathological causes such as spontaneous pneumothorax, which we tend to see on tall, thin, predominantly females. However, men can have them as well. Fractured ribs hurt. Best way to stabilize fractured ribs is much of the time the patients will stabilize themselves because they hurt. But you can also use a sling and swap to help support that chest wall. Pleuritic chest pain, that's where the lung rubs against the inside of the chest wall due generally to decrease surfactant in that area. Dyspnea, shortness of breath, we always want to watch that. Remember, they might be breathing okay, but they also may have an oxygenation issue. Decreased breath sounds, we want to look for that depending on where they're at. Tympany and percussed, so is it hyporesonant, is it hyperresonant? And intention pneumothorax, which is immediately correctable by needle thoracentesis. Sternal fractures, it takes a lot of force to break a sternum. Remember, you can feel it on palpation. We have three parts of our sternum, if you remember. We have our manubrium, which is the top part, our sternal body, and our xiphoid process. So you can get a fracture of your sternum. You always want to assume they have myocardial contusion. These patients get cardiac monitors. These patients get 12 leads. But remember, if someone is showing an ST segment myocardial infarction or any type of myocardial ischemia denoted by ST depression in that case, do not treat these patients like any other cardiac patient. Do not give these people aspirin. Okay? Do not give these people vasodilators. Okay, you're going to make the situation worse. And besides, they're not indicated for chest trauma. And unlike, like I said, we can't rule out chest trauma as far as underlying structures in the field. Maybe as things advance with ultrasound, we may see some better things occurring with that. But as it stands right now, we're not going to see a whole lot of that. So monitor for pneumothorax, monitor for hemothorax. Okay, so remember, chest trauma is very common. They're very much life-threatening. You need to identify them quickly. So do they have those big neck veins? Do they have absent lung sounds? Do they have air hunger? Are they anxious? Are they having cyanosis? Remember, trauma is a surgeon's disease, so you need to get these patients to a trauma center, preferably, and use aeromedical if at all possible, depending on your duration of transport. I'm not saying use helicopters for everything. However, the quickest route to get the patient to a trauma center is appropriate. Airway and oxygenation, always a priority. Remember, airway management and breathing are two different things. So always make sure the airway is open and patent and open and clear, and recess often. Insert an airway if the patient cannot protect the airway themselves. Oxygenate them with supplemental oxygen as available. Use capnography. Remember that pulse oximetry is a measurement of oxygenation, and capnography is a measurement of perfusion, meaning you measure the end-tidal CO2, which is the byproduct of cellular metabolism. Always keep examining these patients. Your exam will start when you meet the patient, and actually your exam technically starts upon dispatch. You start forming an impression at that point. But your physical exam when you're at patient's side, and it should end when you're at patient's bedside at the hospital. So always want to keep evaluating. And don't forget to not get hung up with distracting injuries, such as a patient with a femur fracture, may have a tension pneumothorax. Even though a femur fracture is bad, your partner could throw a dressing on to control bleeding or throw a tourniquet on to control bleeding. And if it's that big of a hemorrhage, but the needle thoracentesis is immediately life-saving. So do not get hung up about that. If a patient has eviscerated abdominal organs, which we'll talk about here shortly, that won't immediately kill somebody, but a patient that has unrecognized tension pneumothorax will. So keep these things in mind. Like I said on most of the past lectures, feel free to contact me through our Facebook group. Feel free to email me at robert.hyman, Hyman, at yahoo.com, or you can send it to my hospital one, robert.hyman at ssmhealth.com. You can reach out to me on Blackboard. However, I'm not logged into Blackboard as much, other than check your discussion boards and things like that. So if you want to get a hold of me, and most of you know how to get a hold of me pretty readily as the year has gone on, don't hesitate to call me if you have any questions at all while you're studying. I'm never put out by asking questions. So if you have questions, don't hesitate to ask me. Okay, just don't call me at 3 in the morning and say, hey, is the integumentary system the largest organ system in the body? I might be less receptive at 3 in the morning for that question. But generally, I'm open to questions all hours of the day or evening or so. So, the best time to ask a question is when you think of it. If you or write them down as you're studying, and then shoot me an email with a whole bunch of questions. And then I could, chances are, if you're thinking of it, some of your classmates are probably thinking of it as well. So if you want to send me, send a question out to like a group text, not a group text, excuse me, but through our Facebook group, I'll be glad to answer it there for everybody to see. So just keep in touch, and we'll get through this COVID stuff and hopefully see you very soon. The next lecture we're going to do will be abdominal trauma.